One of the important thing is the treatments addressing the neural processing. Treatments addressing the neural processing, one could be using the transcutaneous electrical nerve stimulation. The simple electrodes placed on the chest, giving us an electrical low dose electrical stimulation. The mechanism of action could be gate control theory or an endorphin release on improved blood flow. It could be because of from the subcutaneous electrical nerve stimulation. You could use a spinal cord stimulation by placing some electrodes in the C5 to T2 level, or you could even do a cervical sympathectomy. They decrease the sympathetic outflow, improve the myocardial relaxation, and improve the coronary blood flow. This is one of the various modalities which are being processed, not coming to the clinical practice yet. So the European Society of Cardiology has approved the transcutaneous electrical nerve stimulation, wherein the pain signal remodulation and neuromodulation occurs, and there's a reduced afterload. The European Society of Cardiology has agreed for that. The American College of Cardiology and AHA have not approved for this. The spinal cord stimulation is another thing wherein there is a spinal signal neuromodulation, there is a reduced oxygen demand and an improved coronary perfusion. Again, the European Society of Cardiology and the American College of Cardiology have approved this modality of treatment. There are treatments addressing the myocardial perfusion, especially the EECP, and you have the coronary sinus reducer. There's a stent-like device placed in the coronary sinus. The TMLR is almost defunct now, and extracorporeal shockwave myocardial revascularation, another modality. Gene cell therapy, wherein you can using the progenitor cells from the bone marrow to perfuse the myocardium, producing an angiogenic and fibroblast growth factors through a viral vector, the adenovirus, giving us a angiogenesis as well as improvement in the blood flows there. EECP is wherein the blood pressure cuffs are tied to the legs there, sequential high pressure dilatation in the calf and then in the mid thigh and then the proximal thigh at high pressures, 300 millimeters of mercury, going up sequentially and improving the diastolic blood pressure, increasing the coronary perfusion, decreasing the afterload, also promoting collateralization and increased vessel neogenesis there. The coronary sinus reducer is a new therapy which has been approved. It's been there for quite some time, but not yet come into full practice there. Approved by the European Society of Cardiology. It increases the coronary sinus backward pressure to improve the redistribution of the myocardial blood flow, and that is the coronary sinus reducer. This is placed in the coronary sinus at the venous valve here, and it increases the coronary sinus pressure, thereby increasing and redistribution of flow from the subepicardium to the subendocardium, where the ischemia episodes are quite high. There have been 2 or 3 major trials which have very clearly shown that there's an improvement in the CCS class and improvement in the quality of life, the 6-minute walking distance. Even on CPET, the cardiopulmonary exercise testing, they have shown clear benefit with this. The vascular endothelial growth factor, the fibroblast growth factor, and the CD34 and CD133 are the cell therapies which have been proposed. They're still going research. They have not come into the regular practice. But the CD34 plus has shown to be of some promise. The cell therapy in patients with refractory angina, where it has improved the exercise time, the decrease the frequency of angina, and the significant decrease in the all-cause mortality even at 24 months. This is a group of patients who have a significant benefit. This is my last slide. So in patients with refractory angina, probably one need to perform a imaging test to evaluate the ischemia. If the percentage of myocardial ischemia is more than 10%, and there are more than 3 segments involved in the stress-induced hypokinesia, probably one need to perform an invasive angiography, do an FFR or a IFR, and then probably treat the obstructive coronary artery disease depending on the modality of revascularization one wants, or with an obstructive disease not suitable for revascularization. And if it is a left coronary system, one could think of a coronary sinus reducer. The last treatment is only for the left coronary system, not for the right coronary system, because the right coronary system, the valve joins the coronary artery at the mouth itself. For the right coronary system, probably EECP is a better choice, or a neuromodulation, spinal cord stimulation is important. And somebody who has a less than 10% LV myocardium at risk, less than 3 segments of stress-induced ischemia, probably medical therapy tailored with anti-anginal treatment, tailored to the blood pressure and heart rate is very, very important. I think thank you for your patient hearing.